Alzheimer and other forms of dementia, and in particular, tips for the caregivers. You're all very, very warmly welcome to this session. We are purposeful aging, trying to age purposefully. We've been here for over a year now, and I'm happy to say once again that we started off with mental health, and it was given by no other than our facilitator this morning. We do have an email, and I would like to ask all of you to please put your emails in the chat box so that we can keep in touch with you. And in particular, you can always, we can always send you a recording of what has happened. This morning, we are privileged to have Professor Noeline Nakasujja. She's an associate professor of psychiatry and head of department of psychiatry at the College of Health Sciences, Makerere University. She has expertise in geriatric and mental health, and in particular, Alzheimer. Professor Noeline, we are very, very thankful that you are once again here with us today. We are very privileged because it's not easy to have someone of your caliber for more than once in a year. We are happy to have you. We are privileged. And as you see, we have over 40 people online. And it's a mixture of caregivers, not really attendants as such, but caregivers, and a few professionals. But we know, and you also know, that we try to make these sessions as down to earth as possible so that our caregivers and ourselves can know and learn how to look after ourselves back home, this time not in hospitals. You're most welcome this morning. Thank you so much for coming on, and please greet the people and dive straight into it. We have like 30-40 minutes of hearing from you, and then we'll have some questions and comments which will be introduced at the time. Professor Noeline, you're welcome.
Thank you very much, Dr. Philippa. I'm going to share my screen. Just a moment. Oh, sorry. Okay. So, ladies and gentlemen, thank you all for joining online for this follow-up presentation on tips for caregivers that look after patients that have Alzheimer's disease. Now, we may have a few new people, and we may have old people in the presentation. I wanted to ensure that people are able to follow with whatever it is that we are talking about. And therefore, I will begin with a little bit of just to catch up with where we stopped the last time, it is exactly about 1 year and 2 months as checking since we last interacted on this very particular topic. So I just want to also let you know that June is Alzheimer's month. I hope you're seeing my screen, right?
Yes, we are seeing it.
Right. So June is Alzheimer's month, and it's a wonderful opportunity that this talk is taking place at this time for the creation of awareness about Alzheimer's disease. There is, you know, a big concern about the increasing number of people who have Alzheimer's disease, and therefore this comes at a very appropriate time. So spread the word about Alzheimer's disease from whatever it is you're going to learn in this session today, so that people know what it is that they can do with their caregivers. So I also want to just highlight that the majority of people who look after individuals that have Alzheimer's disease are actually the family, and it is very important for them to have some form of support in how they should look after this person, or get tips on how they can be able to look after this very individual. So the Uganda Alzheimer's Association was developed maybe about 5-6 years ago, and we are in a drive to see that we get as many people joining the team. The association is not only for individuals who have Alzheimer's, it is for individuals who may be having caregivers, well-wishers, and anyone who is involved in care of older persons. So who remembers this 1 year ago? I haven't yet looked critically to see who is online. Is Engineer Tusu here? I don't see him, but who does? Philippa, do you?
I don't. I do. It's
I do. I
familiar.
certainly do.
And some of us is going on right now.
Yes. So I brought this up because the last time we
Senior
discussed
moment.
it, yeah,
Yes.
these senior moments where you're not sure whether you went to pick something from upstairs, or have you just come down for something different? So the biggest challenge with Alzheimer's disease is that there's a challenge with short-term memory, and that's what I'm highlighting here. People forget things which have just happened. Their long-term memory may still be okay. They could be able to tell you stories of stuff that happened a long time ago. And sometimes people say, no, but he's able to tell me things. How come he told me when he went to university and when he got married and when the baby was born, and he can't remember the things that have just happened. So that's exactly what happens when individuals have Alzheimer's disease. And the ABCD signs and symptoms of dementia are mostly in 4 areas. That is in the activities of daily living, in the behavior of the person, they may change. The cognition is to do with the way we think and process information that is in our brains in order to be able to plan, make decisions. So this also gets a challenge. And then the other one is about orientation. We will keep on repeating these things from time to time, because the tips for the caregivers that are, I thought it was important for the caregivers to know what the signs may be to begin with, because there are so many people who may have their loved ones and are not sure if at all there's a problem. And that's why I keep on highlighting even the symptoms the person has before we actually go into the management of those particular challenges that the individual may be experiencing. Please let me know if this bar at the bottom is obstructing you. I'm trying to see where. Philippa, is it? The bar.
We see up to, I think, the end of disorientation. Is that what we should see? The word space is the last word.
Yeah. Okay, great. If that's what you see, then that's fine. I'll leave the bar at the bottom. Okay. So, it's also important for us to I think have a revision of what we should consider as normal aging and what may be symptoms of dementia, in terms of how an individual is able to function. So, you know, when we grow old, the purpose is for us to age gracefully, just like your association says, and for one to continue to be an active member of society. It is expected that one can still make new friends, try out new stuff, and, you know, have an independent way of living. They shouldn't be so dependent on other people for the planning of their day-to-day activities. However, when you get an individual who has dementia, these become a challenge. They may not be able to know where they're going, how to get themselves there, how much it is, you know, the power, electricity is over, how do I pay my car or get someone to help me, you know, punch in the numbers if I have challenges with seeing, and stuff like that, that would otherwise make a person not be independent in whatever it is that they are to do. We've just talked about the issue of recalling and being able to describe stuff that has just happened. And a normal aging person may forget, but maybe later on you will remember what you were meant to have said, which is a challenge in individuals that have dementia. Sometimes when we are going places, we may forget, and that's normal. You may pause a little bit and ask yourself, did you turn left? Did you turn right? I don't know whether it's yeah, thank you very much for muting yourself. So going places, you may forget where you're going, but if you're still okay, you may eventually remember, no, I remember. And as typically happens in our Ugandan setting, there was a mango tree there. That mango tree is still there. This is where it is that I take my turn to wherever it is that I'm going. But for people who have dementia, they will forget, even when you place them in very familiar circumstances. They will require direction. There may be occasional difficulties as we grow older in remembering words or finding words for certain things, but they will not impede us from holding a conversation. You may find something to replace what it is you're saying, and the conversation continues. With individuals who have dementia, this becomes a challenge. They may forget the word, they may misuse it, or they may just gumble are things that may not be able to be understood by those who are around them. And then, of course, the last one is the issue about judgment, that people may not be able to make the right decisions. And sometimes they even forget. They may have said yes, and then tomorrow they cannot recall if at all they said yes to that that you're talking about, which is problematic. So today we are talking about Alzheimer's disease and other related dementia, but because Alzheimer's disease is the most common, as I'm going to show in the next few slides, we normally use it as the prototype about to talk about all other types of dementia, because largely to a community person or a lay person, it all may look like it is the same. It is us who, you know, when we get into hospital, that will differentiate which type of dementia the person is having, and therefore appropriate the right treatment for that particular type of dementia. So dementia on the whole, as we've just mentioned, is a problem with memory, thinking, and an inability to carry out the simplest of tasks for day-to-day activities. This is history. This is where it all began about 100 years ago. It's 110, I think now, of this lady who developed dementia at the age of 55. And the gentleman you see was Louis Alzheimer, the doctor who was looking after her, who was befuddled by her presentation, because it was strange to see someone who couldn't be able to name objects, who couldn't say her name, and who was talking about things that were not present in the room, like saying, you know, as you're seeing on the screen, I'm sorry, as you're seeing on the screen, that I just called a child. Okay, my slides jumping. I just called the child. Is he here? And many times people may complain of seeing things that other people may not be able to see as they care for them. It's a common feature for dementia. So that's where it all began. And we need to be worried about Alzheimer's disease because there are more and more people growing older. And as they grow old, the challenge of caregiving for them then falls onto the family. You know, and it creates a lot of problems, as we are going to be seeing. Uganda's population is also increasing, just like everywhere else in the world. So many people keep on asking me, is it Alzheimer's? You've said Alzheimer's dementia, and now you're saying dementia. You're confusing us. Well, what is it that you're talking about? So for purposes of understanding, dementia is an umbrella term, as you see the umbrella, you know, being depicted here. But under it, Alzheimer's disease happens to be the most common type of dementia. Most dementias are progressive once they are started. I'll not talk about the non-progressive ones because that may be beyond the scope of today's presentation. And this is the umbrella, as I've just mentioned. The other types of dementia may include vascular dementia, Lewy body dementia, frontotemporal dementia, Huntington's dementia, mixed dementias that may be due to many other causes, including alcohol, poisons, trauma to the head, and other things. So each of these topics is huge in itself. So I appreciate if we focus a lot more on Alzheimer's. Would require an hour to speak about each one of these different dementias. So if we look specifically for how much the burden is, this is what you see in the pie chart here, that Alzheimer's disease contributes to 50 to 70%, and hence the big focus on it. Vascular dementias that may result from people who may have things like hypertension or cardiac disease contributes about 10 to 15%. And then we have the others, Lewy body dementias, which may be similar to other dementias like Parkinson's dementia, contributing to about 10 to 20%. And then we have the frontotemporal one. So worldwide, we have about 55 million people living with dementia, but that number keeps on increasing. And as I just said earlier, that we need to worry because more and more people are living longer for various reasons, as we previously discussed. So if we're to look at older adults who are over 65, and here are the tips for caregivers, when should we start looking out for, a possibility that a person might have Alzheimer's disease? The majority of people lie between the age of 75 and 84. but the disease can begin it begins very early sometimes, but the commonest age of onset is after 65. However, we do see people who may develop it at 62 or even earlier, like Augusta Dieter, the lady I showed you in the beginning. I'm getting feedback, Philippa.
It's been handled. Sorry about that.
Thank you. So many people ask what causes it. I'm trying to preempt questions that are coming, that may come after, even though we may have talked about this previously. We do not know what causes Alzheimer's disease. I mean, for many of these degenerative conditions, I like to think of degenerative as disintegrating, like the brain has grown up to a certain point, it matured, and now it starts like to crumble and start to disappear. I will show you just a few slides to make the point. We do not know what causes it, but there are things that have been studied to have been associated. And the first one is genes. We've noticed that Alzheimer's disease tends to run in families. It is not automatic, though, that if your father had it, you will also get it, or if your mother had it, you will also get it. But another relative may have it, you know, within the family. And then the other, once the genes have set the pace for the Alzheimer's disease to happen, then you get the environment taking, you know, its course. And we'll talk about the environment as we go along on how it may contribute to an individual developing Alzheimer's. This I'm just showing to show that it is not a thing that happens just suddenly like that, oops, yesterday Mr. X was okay and today he has Alzheimer's disease. No, it is a disease that is progressive. There is a preclinical stage, and there will be no signs, but then this is a person who might have the genes that predispose them. We will not be able to see it like physically, but it will be in that person and it's in the background. And we do have biological clocks in each one of us. So for some of them, it's just the time for when that clock is going to be turned on for you to start to see, for example, the mild symptoms, which may not interfere with everyday activities. They may not even be noticed by other people. However, if one were to be evaluated and we tested them, we could find that, oops, there's a challenge in the way their brain or cognitive functioning is going on. And then the disease progresses through the stages of being mild, moderate, or severe, as we are going to see. So what are the signs? In the early stages, someone may not be able to care for, they may still be able to care for themselves in basic activities. They may have some difficulty in, knowing where to go, where do I stop, money management, challenges with preparing meals. They prepare the meal, they forget to put, one of the ingredients, or they leave the meal on the stove a little too long and maybe it burns up. As the disease progresses, they may require assistance with dressing, personal hygiene, feeding, and other things. And they develop a high risk of falls because they are unstable. The brain is also in charge of our stability on ground, and sometimes this is interfered with as the disease progresses. And then in the advanced stages, an individual is unable to care for their own hygiene totally, and they have to depend on others for much of the time, actually all the time. So then when it gets to behavior, the previous slide I shared was about activities. The bar at the top just shows you the different areas that we kind of concentrate on. So I've just talked about activities of daily living. Now I'm going to talk about apathy. So in the mild stages, people may seem uninterested. That's what we mean by apathy. They were usually very engaged in whatever it is that was going on around them. But then now you start to realize that they seem uninterested in what is going on. It's like they just look at people who are around. Sometimes they may have rapid mood changes. Someone was okay before, then suddenly they are crying, or suddenly they are very annoyed, and you just can't understand what's going on with them. They get to be very picky, irritable. As the disease progresses, they may start to wander in terms of behavior, wandering away from home. When you have conversations with them, they're repeatedly saying things on, again and again, or repeating questions. I have a friend who told me they went to visit, and they greet them in Uganda. You welcome a person. It's an elaborate greeting. Then a few minutes later, the person looks back at them and say, "Hey, and this goes on and on. And it's not that they are very excited to see you, but maybe they are, for them to be greeting you that many times. Individuals get sleep reversal, so they tend not to sleep at night. They may nap during the day, but then at night become very active. There may be frustration at not being able to communicate well, and some of them actually cry when they want to express something, because at this stage, they can still appreciate that there's a challenge with them that is ongoing. And sometimes this can actually end up in depression or agitation and suspiciousness, especially when they can't remember where they kept their stuff and they think people are stealing their things. In the advanced stages, they may cry, they may shout, and you just don't know what it is that they are shouting about. But as we'll talk about going to the tips for caregiving, you will appreciate as to why they are shouting. Usually it's because they are uncomfortable, but do not have the right words to express what it is that they are feeling. And sometimes they may refuse care. You may give them food and they say, "Why are you giving me food? I have already eaten." Because they cannot remember that they actually had a meal that you served them earlier. Then in the cognition. So cognition, as I said earlier, is the way we think, the way we put things together within our brains for planning, for decision making. So in the mild stages, someone may be forgetful. They may have a reduced judgment, where someone makes a decision and you wonder whether that was the right thing for them to do or not to do. Usually big things, not small stuff within the home. They may have difficulty in following storylines and conversations. And then they start to misplace things and can't find the right words to items. As the disease progresses in the moderate stages, they then have they start to get a vague long-term memory or mix up things that previously happened. They may remember they happened, but it's mixed up a little bit. They may start to be unable to recognize certain family members. The family members who are in constant touch with the individual may not face a challenge, but the ones who are not frequently interacting may be confused with other people. Then they have difficulty in communication because of their repetitive speech, and it's difficult for them to understand certain concepts and contexts, and may be unable to remember even where they live, or for people who have addresses and address numbers, may not be able to remember these numbers or their own phone number. In the advanced stages, they're unable to recognize their current self. They're unable to communicate through language, and they are unable to recognize common objects. And then lastly, on the issue of disorientation, because that is a major function of the brain for you to know where you are at what time. In the mild stages of, it's occasional for them to get able to be disoriented, but may be able to navigate between frequently visited places. In the moderate, they get confused with the concept of time and even get lost in familiar circumstances. And then in the late stage, of course, they're unable to even differentiate day from night. They don't know whether it's nighttime or daytime. This next slide talks about, so you can see that I earlier on showed the prodrome and then the mild and then the dementia onset. The way the history runs of the disease is that there are not distinct time points for when one begins and then the other one starts. So there is an overlap, and that's the purpose of this slide, to show you that there is overlap in the symptoms expression, and therefore the moment you see any one of the symptoms, you just quickly come. The challenge as to why these things happen is that the brain cells, which you see in to my left, those are neurons. They are supposed to be communicating to each other in order to pass on messages with the arrows that you're seeing moving from up to down, in order for us to be able to understand and do things the way we do. When Alzheimer's disease comes, there's distraction within these neurons due to a formation of things that should not be there, and therefore the neural cell cannot be able to function well, and it eventually dies. When it dies, that is what you see on here, that we start to get spacing. Previously, the brain is usually very compact, as you see, a normal brain, but when Alzheimer's disease comes in, the cells die and there's shrinkage of the brain, and it is irreplaceable. So the biggest risk factor for dementia is increasing age. Is there anything we can do to stop it? We have a zone in which stuff can be done, possibly for prevention, but as you're going to hear, it's something that starts way earlier. So tips for caregiving. Long before your older, loved one even gets to this stage, you have to encourage the following. And if there are young people who have also tuned in for this presentation, this applies to all of you. You have to begin early. You can't wait till you're 60 and then you say, oops, I have to start doing things to prevent myself from getting dementia. So one, you see there, the issue of gender. Unfortunately, females tend to be more affected by the condition, but also females tend to live longer. So is it an issue of age? Is it an issue of genes when it gets to Alzheimer's disease? In our environment, we are talking about things about brain stimulation. We are talking about education. We are talking about, social interaction. How much of these are happening within us for them to possibly help us prevent dementia when we grow old. Health-wise, are we looking after ourselves? Do we manage diabetes, hypertension very well? So if you're caregiving for an older adult, how well controlled are they in regards to these things? How often are they having a checkup just to be sure that everything is going on well? What are the levels of their cholesterol in their bodies? Because these are things that also may be problematic in terms of developing dementia. Behavior-wise, what activities are people doing? What social groups do you belong to? What games or physical exercise do you engage in? Of course, we cannot change our genetics. Unfortunately, that one is in a green. We can't do much about it. But if you control for the others, much of the time genes get expressed because of what is happening in us as individuals and in the environment. So possibly you can prevent the occurrence of Alzheimer's, even if you're predisposed, if you catered for the others, three things in the environment, health, and behavior. So these are the medical conditions. If you have any of them, make sure you're treating them well. We have the metabolic, and then we have HIV, metabolic, hypertension, cholesterol, any chronic infection any person might have, diabetes. HIV mentioned here because for it may, if untreated, can actually bring dementia very early on, even if you're in your 20s or 30s. So tips for caregivers, but at the same time, tips for the older adults as they're going. We shared a few of these slides before. There's what is normal drinking and what is considered as not normal. So please, no more than 1 standard drink per day for older adults. That is, you shouldn't take more than that. Do not take more than 2 to 3 drinks on any drinking day because that is considered binging. Do not smoke. Get plenty of exercise. So if you're caregiving, even after people are older, these things are still encouraged because they play a big role in, if at all people have developed cognitive impairment, it still will help in the slowing of decline for the individual. I've talked about the management of health problems, and very important for you to look at the diet, lots of green vegetables, lots of fruit, and avoiding a lot of fatty foods. Do exercise with colleagues, with your partner, alone. I show here, it's not that I'm marketing Zumba, the Zumba squad, but my gym instructor is this lady in yellow who is taking a certain pose. And she talks about this openly. I don't know how old she is, but I know she's over 60 and she's our gym instructor. Can you imagine? So the sky is the limit for you if you want to keep physical, have mental alertness through reading, through jigsaw puzzle doing, because this is brain exercising. Engage in community, allow this person, even if they do have cognitive impairment, to engage in community activities as best as possible. As shown in these pictures, it could be a church activity, it could be a community activity, but get these individuals together to paint and do stuff that helps stimulate the brain. 1/4 of adults who are over 65 have been found to be socially isolated. They don't have, and these are worldwide figures. I'm not talking about Uganda because they are living maybe a little different, though it is increasingly also tending towards that people may be in their houses and have very minimal social interaction with other people. You may say that they do have a caregiver, but if, or someone in the home looking after them, but if they are not engaging with that person, if they are not having constructive conversation with that person, they are still considered lonely. It's okay to start a hobby if you didn't have one, or for the older person, it is okay for them to engage in, knitting. If you didn't know how to knit, join a book club as you grow older, and connect with young people. I know Dr. Kadama really likes to engage with her grandchildren. These help to stimulate you and teach you new stuff. It's not that older people should not be learning new things. It is very possible for that to happen. Give back to the community, volunteer, encourage them to volunteer in community activities while they still can. And then, of course, there is the issue of ensuring, as a caregiver, before your person becomes very deteriorated in cognitive functioning, to ensure that you help them in planning their documents. Let people know, where do you want to be buried? With your money, who do you want it to get it? And, you know, how do you want to be cared for? And stuff like that. So this is the role of the caregiver as they look after their older adults. Now, tips for caregivers are very elaborate, and time cannot allow us to go into each one of them, but I'm going to give examples of them, but we will share. The link I show here is the link for the World Alzheimer's Organization, and there is a lot of detail for any of these things that affect individuals with Alzheimer's disease. So, for example, for this presentation, I'll only talk about communication and incontinence, but there's all the other things. As a person who is looking after an individual who has Alzheimer's disease, what do you do about their dental care? How do you, ensure that their teeth are clean? Because very often they may get caries, and if they cannot communicate well to you, you may not know why they are uncomfortable because they don't have the words to tell you. So ensure that there's good dental hygiene, medication safety. Don't give them drugs to give to themselves, because judgment and being able to know whether they took a tablet already or haven't yet done so is a big problem. Get them, what do we call them? Drug dispensers that have days and maybe time of day. They're sold in pharmacies, to know whether you arrange the drugs and you put the morning dose and the evening dose, so that there is no confusion in case you are to leave the house. And ensure that their hypertension DM is well catered for. There's tips on everything, as you're seeing here: what food to eat, when to bathe, because this also becomes a problem with them refusing to go for any of these things. If there's time at the end, I will open the websites just so you see how to navigate it. But all these things are in there. So let's talk about communication. So we already mentioned that people may have challenges in being able to have the right words to say, and therefore they may choose to keep quiet, or, you will just have difficulties in, being able to communicate with them. So as a caregiver, do not make assumptions that, well, they are not understanding, I shouldn't bother talking to them. The disease affects people in different ways, so do not exclude people from conversations. Try to be involve them as much as is possible. However, you need to speak to them directly. You may need to speak slowly in order for them to, understand what it is that you're talking about, and also give them a chance to respond. Don't be in a rush. As we've said before, they have difficulties in finding the right word. So give them an opportunity to find that word and then be able to tell you what it is. Try not to interrupt unless if you think you've waited long enough and, maybe it's time for you to now say something. Ask what the person is still comfortable doing by themselves, and what they may need help with, rather than assuming everything that they once diagnosed with a disease that they cannot be able to do for themselves. So choose the best method of communication, as you see, face-to-face, email. So being that, or phone calls, being that your parents may be in the village doesn't mean that you can only communicate to them until you go to visit them. And sometimes it's okay to laugh. It is, if it is funny, but please don't laugh at them. Because humor sometimes helps to lighten, difficult situations. In the middle stages, it becomes more and more important for you to engage on a one-on-one, because if you're hoping that you're going to communicate to them in a group, that may be a bit of a challenge, because much of the time they would rather they just keep quiet. Make sure you maintain eye contact as you're communicating to this person, and be patient and offer reassurance. Avoid criticizing or correcting. Instead, listen and try to find the meaning in what the person was saying. And patience, really does help, because eventually you may get to appreciate what they are talking about. You should also avoid arguing, because when you argue with them, then they also get agitated. And then, that becomes a very not so pleasant way to be with people. Sometimes it helps to give visual cues if you think the person has failed to, get the right word for them to say. You could demonstrate a task to encourage participation. For example, if you want them to shower, or sometimes they start doing odd behaviors, as you're going to see. So you just join in with them, and maybe you eventually get them to take that shower if that they have been refusing. Where they can, writing sometimes helps, but they have to be big letters, because much of the time, many of these individuals cannot see clearly. I'll finish in the next 10. So, or before. In the late stages, as we said, talking may completely be gone. So it may be good for you to first identify yourself. You have to keep on reminding these individuals of who you are. And sometimes you may just have to encourage nonverbal conversation. If you don't understand what the person is trying to say, ask him or her to point or gesture. Touch is very important for these people. So sometimes just even touching their hand, it helps for them to feel calm, and that there are people who are around them. Consider their feelings more than the words behind those sounds. And treat the person with dignity and respect. Avoid talking down on them or as if they were not present in the room. Take them as like they were part of everyone else who is present. And sometimes you may not know what to say, but just sitting there with them may be okay. And engaging in conversation or trying to keep them up to date. As to whether they'll remember that stuff, that's another story, but sometimes they'll surprise you in remembering that, oh, yes, you said that before, and they can identify. The other second thing I want to talk about was incontinence. And I'm not going to go into all the details of where it comes from, but sometimes it's infection, sometimes it's the nerves themselves. So make it easy to find the bathroom and use the toilet. I always advise clients to label the toilet with, so that people know this is the toilet. At night, it helps if you leave a little light or something that another person can be able to follow to get to that toilet. Or sometimes using a bedpan or a pail, as some people do in our setting, may be helpful for them to be able not to, soil themselves, because the walk to the toilet sometimes is a little too far. remove, plants, waste baskets, and other objects, which may be mistaken for a toilet, because that happens a lot. Now, the caregiver, in the last minutes, the tips were for the caregivers, but now these are also tips for the caregivers as themselves, who are looking after a person with Alzheimer's disease. 60% of people who look after individuals with Alzheimer's disease are women. 30% of dementia caregivers are daughters. So that says something. We need to see how we put hands together in looking after older persons. This job should not only be for the female daughter or the one person in the family to look after this individual. It should be a shared responsibility in whichever way you see it, because it's really a very taxing one, as I'm going to mention. So among primary caregivers of people with dementia, 50% of them are looking after parents. So in Uganda too, these days, it's not uncommon for people to find either nurse or a live-in maid who may be looking after someone with Alzheimer's disease. So they constitute the other 50%. But can you imagine 50% of people are looking after their own parents, and yet sometimes they are the breadwinner and have to be able to find the food that this person has to eat. So 23% of people who look after Alzheimer's disease are what are called sandwich generation givers. So usually they also have their own children that they are looking after, and that can be a bit of a challenge. I'm going to jump this in the interest of time, but there are issues. It was a slide about sleep. It should have come before. And what one should do when someone cannot be able to sleep at night. But maybe let me just pick a 1 or 2 points. Usually, first find out, you need to study this individual and find out what makes them comfortable and what makes them uncomfortable. Much of the time when they get agitated, it's because something has made them uncomfortable. They're either in pain or distress, or they're hungry, as something is not right. So first find out if all that is okay. Avoid arguing, reassure them, sit with them that, things are okay. Sometimes they may be seeing things which other people are not seeing. Maybe before you get them to hospital, you try to offer reassurance and ensure that their home is well lit for them not to be confused about images they may be misinterpreting. And sometimes it helps to just keep with them, for them to, sit with them or walk with them as is possible. Avoid daytime sleeping or napping, because then it decreases the amount of sleep the individual has. So coming back to the caregivers, we do know the caregivers can suffer a lot of emotional, physical, and financial challenges because this person has to be looked after 24/7, and that can be a big problem. So the common signs of caregiver stress: 1, denial. People deny that their individuals have the disease, and that is not helpful, because then they delay to get help for that individual. The more the disease progresses, as you've seen in the slides I've presented, the more difficult that person becomes. So if you delay to bring them in for care, it becomes rather difficult for you as a caregiver. People who are caregiving often experience anger towards the older person, because they think, sometimes I'm blown away with the attitude of the caregivers. So they think the person is pretending. There are instances where people can do number 2s and then decide to smear the number 2 on the walls. And that usually will elicit anger. And if one is not understanding enough to know that this person is not doing it because they want to, oftentimes it can also result in elder abuse. People are beaten up, pinched, slapped, whatever it is. Caregivers often may also socially withdraw because this is a 24/7 job. So they keep away from friends, they keep away from activities. And I've said earlier, it is important for this job to be a shared activity so that an individual's life is not cut off just because they have a family member who has Alzheimer's disease. There needs to be time for one to also be able to interact with themselves or carry on other activities. They often suffer anxiety about the future, and especially in looking after this individual, and also if it happens to be a problematic patient, they will get depression, they get exhaustion, they may also be having problems with sleeplessness because the person, for example, if the individual with Alzheimer's is agitated and keeps awake all the time, they're moving, in the house all the time, so they also do not sleep. And then, of course, irritability. If you're not sleeping, you're going to be irritable yourself and negative generally, and may have poor concentration as a result. So I think I'm jumping to the last slide to keep within time. So as a caregiver, one needs support from all these different areas. A caregiver needs to have ways of how they can cope in the caregiving process. As I have mentioned, things like socially interacting so that one can have a life of their own or carry on with other activities is important. Your life can't come to a standstill because of caregiving. The caregiver also needs emotional support. So you need to create a community around you or people who can offer you this emotional support. Don't keep away. There needs to be, so in some respite resources are in countries where you have either day care services. You can carry this older person to that home. They keep the person for the day. You carry on with whatever you have to do, and then you do your job at night for caregiving. In our community, we can take rotational turns in looking after this older person in order for one to have some rest in caregiving. And it is important for the caregiver to also look after themselves, their own health and wellness. Your life, as I've mentioned before, shouldn't come to a standstill because of caregiving. Look at alternative ways to create an hour or two for you to also go and have your own physical exercise, or meet up with a friend or so. And in the home, you can always have a household assistance. We've talked about the issue of gender, with females being the main people that are looking after these older adults. And somehow we have to see how we create a gender balance in caregiving and providing for this older adult. It's not the job of the one person. And we've talked about the leisure activities, that please create time for your own leisure and reinforce caregiver social activities. You have to be caring for yourself. No one will do it for you as a caregiver. Otherwise, you get burnout, and your own quality of life as a caregiver is greatly affected. And with that, I promised Philip I would finish at 11. I come to the end of our presentation, and we go into the Q&A. Thank you for your attention.
Thank you so much, Professor Noeline. I'm sure the over 100 participants this morning, you have all been touched. I have been touched greatly This is a lot of information we have been missing. We have been lacking, not only missing, but lacking, and yet it's so important. Professor, you mentioned this is June, a month for Alzheimer, and I must say this is very, very fortunate because it has also come after purposeful aging has tried to get to help the seniors who have been attending the sessions to take out time for activities. I remember we had a hybrid session where we went through exercises you can do as a senior. We went through a hybrid session, the most recent one, where we looked at how to prepare ourselves for the evening of life. And all these have been pointed out as useful tips for the elders, and more so the tips for the caregivers have been very, very enlightening. I want to thank you so much. I want to thank you all the participants. And I know you have been busy in the chat box. I would like to, at this juncture, to ask Dr. Philippa to help us run through the chat box so that we answer some of the questions which may have been unanswered through the session. And also, we would like to have you participants raise some comments. You can raise up your hand for contributions to this session. Thank you so much for, it's been a very enlightening session. Are there any hands up, please, at present?
While we wait for people to raise their hands, I could give the two questions that have come up. We've had mostly comments and contacts for people to receive the recording. But we had one question that came in early. Someone asked why the association is called the Alzheimer's Association and not Dementia Association, given that dementia is a broader term. And there's another question about do we need a diagnosis? And if yes, how do you get someone elderly to go for one without creating stress or fear?
Okay, so unfortunately, I cannot change the name of the association. The reason being that there are different associations for all those conditions. So there's an association for Parkinson's dementia. Why? Because the way it's managed and the treatments are a little different from what may affect a person who has Alzheimer's dementia. So, and as also I said earlier, the percentage of individuals who have Alzheimer's dementia among all people who have dementia is about 70%. So much of the time we are moved by numbers so that whatever services that are being prepared are kind of focused. But I've been to Nairobi and they run all their associations together. So the Parkinson's Dementia Association very gladly interacts with Alzheimer's Association, Dementia Association, because there is some bit of overlap, but they also have their unique needs that are catered for that way. Do you need a diagnosis? Yes, you do need a diagnosis because frontotemporal dementia, which I talked about, that contributes about 15%, and Alzheimer's dementia, sometimes in their presentation, it can be very confusing, and yet the medications we have available for Alzheimer's dementia may not play any role in a person who has, say, frontotemporal dementia. And also when it comes to managing things like Parkinson's dementia, if you just took it as an umbrella term and just gave that person anti-dementia medication. That may be a problem because there are some drugs that work in certain types of those other dementias that may not work in other forms of dementia. So yes, you did need that diagnosis. How do you get an older person? Please start now. Start now by taking these people. I talked about health, taking them for checkups and stuff like that so that it is routine, even when you bring them in for that evaluation that will look into what their cognitive abilities or brain function activities are in order for us to be able to do something. So let's develop a culture of checkup. We hardly ever do it. We normally just wait until there's a problem, and then individuals come to a clinic, whether for hypertension or diabetes. And yet, even for those conditions, we need to be having, you know, once a year, go and check if your sugars are okay. Go check if your blood pressure is fine. So that's the way you entice them. Otherwise, I usually tell people, you know what, just tell them you're coming for a checkup, and that they're just going to have a conversation with me, which is what I do. And then from there, we entice them into whatever other evaluations may be needed to guide and management. Philippa, back to you.
Right, thank you, Prof. We've had a few more questions, mostly asking for your contact, but there's also one asking for the contact of your Zumba instructor. I'm sure people would like to join that. Maybe you can let us know where they are so that people can attend those sessions. There's also a request for sessions for seniors to do physical activity so that the seniors don't think that it's the caregivers who are just pushing them. I think Purposeful Aging has done a session like that before. We'll just urge you to post your contact, email, and phone in the chat for those who need those sessions so that when they come up, we are able to get in touch with you to bring the seniors.
Okay.
Yes, maybe you can tell us about the Zumba.
So we do Zumba class. This Zumba class rotates around Kampala. So they have a class in Kabira, and then they have a class at Acacia Mall on Thursday, on Thursdays. And then there's another class in some other place. At the Speak Apartments next to Hotel Africana. Those are the different places that I know of where they go. So Kabira, Acacia Mall, and Paradise, I think they call it Paradise Fitness, the one which is at Kabira, rather, which is at Speak Apartments next to Hotel Africana. My contact, Philippa, you'll have to advise me, but I think I'll tell you where I practice from. So I see clients at the IMC clinic in Kololo, but there's also services in Mulago Hospital, at the mental health clinic. We've also just gotten a geriatrician, Dr. Michael Sonko, who is very willing to take on with evaluations of individuals who may think they have challenges with cognitive functioning. And my phone number, maybe Philippa, you can post it. Please kindly text, don't call, because I may not pick. Not that I don't want to pick your calls, but because much of the time I'm either teaching or talking to clients and I may not interrupt that time. But I'll certainly get back to you if you sent me a message.
All right, thank you, Prof. Another question came in about, are there awareness campaigns on dementia running on radios in different languages? Another question about where can one take a senior for ED tests? And then does Alzheimer's predispose adults to stroke and convulsions? Blood pressures
Philippa,
and sugars?
Philippa, please go slow. Question at a time.
Okay, sorry.
You're dealing with
maybe.
possibly older adults. Yeah.
All right, to handle those.
Yeah.
You could handle those first up, whether there are awareness campaigns going on in different languages and where to take someone for tests.
Okay. So the awareness campaigns from time to time, I may be on radio or TV, but there are also other people who promote the cause for older adults. And now purposeful aging, I guess you're being given a task to be more visible. I've been to radio to speak in English and Luganda, the languages that I'm maybe conversant with, but this is a great question for one to ask, because then it shows us the need to offer better communication in other languages. So possibly that's something that we are going to take up. Where can someone go for testing? You can go for testing if you have concerns about your memory to a neurologist or psychiatrist, because we kind of do, when it gets to Alzheimer's dementia, we share that space. But specifically, the memory clinic that we are setting up is going to be in Mulago, Bosa Mental Health Clinic, and it will run on Fridays. Is there something I missed?
Okay. There's one about we give patients supplements once in a while. Have you found these helpful sometime?
Only once. So depending on the type of dementia the person has, I think that's where we go, because sometimes the dementias are due to deficiencies in vitamins, and in those kind of individuals, yes, if we were to supplement that deficiency, there will be improvement. However, if someone has Alzheimer's disease, supplementation alone is not going to be helpful for that person. It isn't, because the mechanism, I didn't go into the mechanism and stuff like that. There's no way that is helpful, and all the studies that have been done still do not show that much benefit, and yet they are very costly. So I usually advise patients, please go eat your usual local food. Go eat dodo, nakati, go eat pineapples, bananas, the usual stuff that we are fortunate to be endowed with in Uganda. We have a lot of variety of food that we can feed on. So supplementation, there's the usual multivit for individuals, or wellness tablets for individuals that is general over a certain age limit. Those are okay, but to say that they are treating dementia, no.
All right. Does Alzheimer's predispose to stroke and convulsions? And then a second one, is there a deliberate plan or strategy by government or private or NGO towards dementia management in rural areas or upcountry Uganda? We could take those.
So, no, Alzheimer's disease on its own does not cause stroke and convulsions. When I hear that, I'm thinking vascular dementia, because in that type of dementia, there's challenges with brain vessels, and many times people get micro clots in the brain, which can result in stroke and convulsion. So that is a different type of dementia, and it will need to be managed differently with the right medications for hypertension and the clearance of those brain vessels, so that there's no clogging in the brain vessels. So is there any plan for government to reach out? Well, you're asking me difficult questions about health generally in Uganda and what is being done about it. But but certainly there is at least a recognition by the ministries of gender that older people require, have their concerns that require better planning in order to offer service to the people down in all the different villages. Otherwise, as the health structure is currently running, you can receive services when you go to any health facility near you, wherever it is that you may be. The challenges usually come with the healthcare person who is looking after you, the expertise that they may have, the availability of the medication that is available. And oftentimes people do referrals once they identify these individuals. Challenges then come with availability of transport and stuff like that for those people to eventually get to us. But we don't want people traveling all the way from Mbarara to Kampala or from Kabera Maido to Kampala for treatment. They can receive care at the health centers that are near them, but certainly, you know, there's more that needs to be done. I think that's what I would say.
That's right. Yeah, thank you. There's a question about how effective is Gensomine? And then is there food to eat and or avoid to prevent the condition? And then is there evidence of slowing progress or reverse the dementia? And does Alzheimer's itself lead to death?
Come again on the last one.
Is there evidence of slowing progress or reversal of dementia? And does Alzheimer by itself lead to death?
Okay, so Gensomine. Studies have been done. It's not conclusive as to whether it can really treat dementia. I will say this again, I said it at the beginning, but we do not know the cause of dementia. You know, apart from things like vascular, but Alzheimer's, we do not know why the changes that happen, as I showed in the slides, do happen. If the moment that cause is found, we'll get the actual drug or treatment that can reverse the situation. So Gensomine, you can give it, but there are no conclusive studies, and I will never give it in isolation. If at all I were to prescribe it, it's not on my #1 list. I can supplement. I put it in the same category of supplements, if at all it were to be used. Is there a food one can eat? The usual healthy foods. Just avoid burgers and pizzas and, you know, that kind of food. Eat everything in moderation. Lots of vegetables and fruits in your diet is helpful because those vitamins play a key role. There's one vitamin that I like to add on my treatments, and that's vitamin E, because studies have been done about it. Still not conclusive as Gensomine, but I think when added with the medications we use for Alzheimer's disease, it is helpful. Is there any medication to slow progress? Certainly. If you come early enough, we do have medications that can slow progress of dementia, prolong your functionality before you deteriorate to the points that I highlighted in the presentation. So can we reverse dementia? Never. You cannot reverse. I can only slow. So maybe what you may be seeing as improvement is, I mean, there are things that may pick up because of the way the drugs actually function. But I also showed you slides of brain cells that have been damaged, and those cannot be replaced. A few times, brain cells have what we call plasticity. They can take on the activity of neighboring cells to help with certain functions of the brain, but that is with limitation in an already old brain. It happens a lot in younger brains, but not so much for older brains. But a lot also happens in the caregiving process beyond the medication. So I don't want people to think the management of Alzheimer's disease is so much about the drugs per se. It is a lot to do with the caregiver as well, in understanding the person they are looking after, what agitates them, what keeps them calm, you know, what do they enjoy doing. Older adults, sometimes for some reason, we found that they like to dance, they like music. So engaging them in a dance or a song, be it a church song or whatever kind of song that they like to, you know, sing before, is usually helpful. Alzheimer's disease per se, because the degeneration eventually will spread to many parts of the brain, but much of the time they die from the other things that have afflicted them. So your kidneys will eventually go, your heart, your, you know, other things come into your body and they will kill you. Your lungs, you may die from a pneumonia, but Alzheimer's per se may not kill you.
All right, thank you very much. Sorry, just two more questions. Can a traumatic event accelerate dementia, for example, car accident or being kidnapped? And the last question is an interesting one. What can you say about AI research to address dementia reversal or halt progress?
Come again on the last one. AI,
artificial intelligence.
Oh, AI
what
research,
can you
right.
say? Yeah, what can you say about AI research to address dementia reversal or halt progress?
So let me begin with the first one on trauma. Yes, traumatic events can accelerate your development to dementia if you get damage to your brain cells. So the trauma may be a one-time occurrence, or it could be repetitive trauma. One-time occurrence, severe damage to the brain, etc. Yes, you will have impairments in your cognitive functioning that will affect all the things that we talked about in your ability to function from a day-to-day and in your ability to think or even recall stuff. So yes, you can have traumatic dementia from a one-time event, but you can also have traumatic dementia as results from boxers. So because they get repeated boxers and people who play, you know, these hard sports, that contact sports, where there may be chances of repeated trauma to the head because it results in brain cells being damaged, you know, and over time, as those individuals grow older, the chances of them having impairment also become very high, versus another similar individual who may not have suffered a traumatic event. However, being kidnapped, being taken away without being beaten on the head cannot result in dementia. What can you say about AI research? I am not, you know, AI has come about, I don't know in which aspect you, Chris, is asking this question. But if you appreciate the pathology of how dementia comes about, I don't see how AI can do anything in changing that until we get to appreciate what the actual, we can see the pathology, we know the processes of what goes wrong within the brain, but we yet do not know why it starts in the first place for certain individuals and why it does not, why it doesn't in other people. Yes, I can see what you're saying. Messaging to brain cells to direct reconstitution, but remember in Alzheimer's disease, the cells die. They die. So if you can figure out why it is that they are dying, why amyloid starts to get packaged in the first place within brain cells, or why the cement of the tubules in the brain starts to disintegrate. If AI can figure that out, maybe possibly we'll get an answer to Alzheimer's disease, but I think that's still early research. Philippa, back to you.
Thank you, Prof. That was the last of our questions. I'll hand back to the moderator.
Thank you very much, Philippa. Yes, I've noticed some Mr. Beckerson, who wants the classes to be extended to Karamoja. When we began these sessions, we encouraged each one of us to start a cell within their limitations and locations. And we'll be very happy to link with you in Karamoja virtually to give you the courage and the support you need for dissemination. And also to our great facilitator this morning, I've had calls from Mbarara, where the seniors in Mbarara are being asked all about the aging, and they have taken your contact, so you might be getting calls from Mbarara. At this juncture, I would like to ask Dr. Javira Makanga to wrap up this session in a few words. Then we get a closing remark. Dr. Javira.
Thank you, Anna. And once again, as on behalf of the listeners, we would like to thank you, Professor Noeline, for the excellent, very elaborate and extensive overview of dementia. I noticed, I think this has probably been the highest number of attendance with over 140 people. Since it's probably gives us a sign that the gravity of the importance and significance of the burden of this problem. Professor Noeline did mention that this is a very common problem. It is most times misdiagnosed or mismanaged, and many of these patients are probably isolated, probably because of the myths and perceptions that our society has. And she has tried to clear out all these myths about this disease. She also did mention that any one of us is at risk of getting this problem, and just because most of the causes of dementia are not known. However, she did mention a few other diabetes, which we've discussed on this forum before. High cholesterol, HIV, for example, of quite vary. She did mention it usually starts with memory lapses, especially your short-term memory. If you remember the first slide she showed us, some people present with a reversal of their sleep patterns. We're supposed to be asleep in the night and awake during the day. This condition might present with the reverse. And for some of us who happen to treat a few people, this reverse of the sleep pattern, when people, especially the elderly, wake up in the night, probably from dementia, probably one of the many head injuries and fractures. A keen eye on some of these manifestations. Professor Noeline did also put special emphasis on the care of this condition. It's a multidisciplinary care. It starts with good, the prevention. First of all, preventing the smoke and all that, but also something very important that I picked out here was something to do with the caregivers that are most often neglected. This is a 24-hour job, like she mentioned, so these caregivers should not be completely ignored. They burn out, and yet they have to watch these people on a daily. So, and she has managed to give a treatment plan and where people can find the treatment. The care is there, the treatment is there. The problem is not curable, but probably can be slowed. All can be prevented in some cases. So with those few, thank you, Professor Noeline, for coming back yet again on this very important topic. Given the number and the questions that were going on, I imagine had we given you more time, there was still a lot more to discuss about this topic. So hopefully in future, you might be requested humbly to come back and discuss a little more about it. Thank you once again, and thank you audience for being very attentive and very cooperative. And we wish you well and a very happy Saturday. Back to you, moderator.
Thank you so much, Dr. Javira. Thank you so much, audience. Thank you for putting your emails and telephones in the chat box. We shall endeavor to reach you, and be assured the recording is accessible on our YouTube, and we shall send you the contact through your emails. Professor, this has been great. I really can't add any more words to that. Thank you so much, and please come again as you've been doing whenever we call upon you. And each one of us, please take note and age purposefully. See you at the end of July, last Saturday at 10 a.m. Thank you and bye.
Bye-bye. Thank you.
Bye.
Bye-bye.
Bye-bye.